Hello, and welcome back to Electronic Health Records. We are picking up with Chapter 4, and if you want to follow along in the textbook, you can follow along starting on page 6. In Chapter 4, we're going to be talking about the administrative management piece of Electronic Health Records. So, starting over on 106, we're going to get into our little introduction here. So, healthcare providers create and maintain an individual's health record for every patient. Each health record contains the reason for the visit, the services rendered, diagnoses, and recommended treatments. Regardless of whether the patient is treated in a clinic, hospital, physical therapy facility, or imaging clinic, his or her health records require administrative management. Dropping down to the bottom of that page, generally the initial contact for a patient is the healthcare personnel at the admission or registration desk. This person, called a registrar, is often required to collect information before and at the time the patient is seen. Increasingly, healthcare facilities may refer to professionals performing the registration or admission process as patient access specialists. At the initial visit, the patient provides demographic information that connects the registrar to the correct record. If no record exists for the patient, the registrar must create a new record and add it to the master patient index. Depending on the nature of the appointment, patient information may be new or may require updating. Such information as insurance coverage, contact information, or demographic data. The Health Insurance Portability and Accountability Act Notice of Privacy Practices for PHI and the Advanced Directives Notice are also given at registration. Copayments or coinsurance for acute care and for outpatient services at a hospital are collected at the time of service. Collecting accurate information from the patient is a critical job requirement for the registrar who completes the admission and registration process for the patient. Accurate data entry is also crucial to ensuring patient safety and preventing any communication problems among providers. So we're going to get into our different types of healthcare settings. So in Chapter 2, we talked about how there's two main settings. You have acute care and you have ambulatory care. An acute care facility's goal is to care for the patient who have short-term illnesses and require an overnight stay in the hospital. Acute care facilities provide around-the-clock diagnostic, surgical, and therapeutic care to patients. An ambulatory care facility provides care to patients who do not require an overnight stay. Ambulatory care centers have grown within the past 30 years as technology has improved and fewer medical procedures require patients to stay overnight. In addition, health insurance has changed how patients pay for services and procedures, and many policies will not cover extended overnight care in a hospital if it's not medically necessary. There are times when a patient may go to an ambulatory care facility for a procedure and complications occur, requiring that patient to be admitted to an acute care facility. The patient would then be an acute care patient rather than an ambulatory care patient. Alright, so let's break down our two different types. So let's get into acute care first. Hospital personnel provide acute care to patients who experience sudden health issues or illnesses and cannot be treated in an outpatient care facility. Patients requiring acute care are either admitted to a hospital through the emergency department or sent from an outpatient clinic or a physician. Acute care can range from a minimum stay of 24 hours to a maximum stay of 30 days, although exceptions to this guideline may occur. For example, if a patient dies before treatment, this patient is still considered an acute care because the physician planned for the patient to be admitted. The day and time the patient is admitted to the acute care facility is the admission date. The admission registrar is the initial contact with the patient, which is in part why this interaction is increasingly referred to as patient access. In the acute care setting, the patient will receive room, board, and care from the hospital. The day and time the patient leaves the facility are considered the discharge date. A patient is admitted to the hospital by the physician, who must document the admission order in the patient record. The physician must also document a discharge order to officially discharge the patient from the hospital. Alright, so let's move down to our ambulatory care. Ambulatory care includes services provided to patients that do not require hospitalization or institutionalization. In most cases, the patient is discharged from the ambulatory care center in less than 24 hours. However, there are some exceptions to this rule, such as the patient who's placed in observation status. Ambulatory care settings are numerous and include, but are not limited to, your birthing centers, cancer treatment centers, clinics, correctional facilities, dentist offices, dialysis clinics, emergency departments, home care, physician offices, surgery centers, therapeutic services, and urgent care centers. Although gathering patient data is similar within an acute care and ambulatory care setting, there are some differences. But let's look at our similarities first. Thorough documentation is needed for safe patient care, and the HIPAA privacy and security provisions apply to both. So you can look at the page 108, and you can see this same table 4.1, but these are the differences in patient data between the two settings. So patient contact at acute care is going to happen as the patient is admitted. Ambulatory care is scheduling an appointment. Health record content for acute care is going to include your history and physical, your diagnostic records, treatment records, and a discharge summary. And then typically your ambulatory care is going to contain your SOAP notes, progress notes, or your chart notes. Let's talk about terminology. In an acute care, the visit is called an admission. In ambulatory care, it is called a visit. Length of stay for acute care we talked about is typically more than 24 hours. And in ambulatory care, it is less than 24 hours. Our list of patients in the acute care world is the Master Patient Index, and in the ambulatory care world, it's our patient list. And then at completion of patient care, we talked about the patient being discharged. And in the ambulatory care, you are checking out. All right, so let's talk about a few other healthcare settings. So a few other settings are identified either by length of stay or by specialty of care. Long-term care typically has patients who reside more than 30 days. A behavioral health setting provides care to patients with psychiatric diagnoses. The facility may offer a combination of acute care and ambulatory care for patients. A rehabilitation facility may also offer acute care and ambulatory care, typically serving patients recovering from accidents, injuries, or surgeries. And hospice care. This is palliative, it's short term, and care is provided to terminally ill patients within acute care or home care settings. The purpose of hospice is to make patients comfortable until death and to support their families during this difficult time. All right, so let's talk about patient entry into the healthcare system. Patients enter healthcare facilities for a number of reasons. For example, patients might be urgently admitted to a hospital via the emergency room, a nursing home, or an emergency from home. A patient may also be admitted electively for the delivery of a child or other medical or surgical treatment requiring an overnight stay in the hospital. Patients might also be treated at the hospital as an outpatient. Outpatients treated at an acute care hospital might be treated in the emergency room and released to their homes without the need to be admitted to the hospital. Patients may also be treated as outpatients when they are seen in a clinic setting or a testing area. Many hospitals also have outpatient surgical centers where patients may have minor surgery and are sent home without the need to spend the night. Patients may be treated in a variety of outpatient settings, including a physician's office, drug or alcohol treatment center, psychologist's office, or a dialysis facility. One thing that all of these patients have in common is that they need to be admitted or registered in the EHR prior to care and treatment. All right, so let's talk about admission and registration. The admission or registration begins when the patient or healthcare provider contacts the acute care or ambulatory care facility to make an appointment or schedule an admission in person or by telephone, email, or secure patient portal. Some ambulatory care facilities provide an opportunity for patients to register by using a self-service kiosk, which is a computer station located in the patient waiting area that connects newly entered patient information to the registration system. If the healthcare facility uses a combination of electronic and paper forms for registration, a patient may download forms from a healthcare website, or forms may be provided by mail, email, or in person when the patient arrives. Registration clerks might also telephone the patient to collect information over the phone. All of these methods of data collection help streamline the registration process and reduce the amount of face-to-face time needed upon arrival. In addition to demographic information, the data collected also includes payer information. This information is used to determine patient benefits and any required approvals from a third-party payer. All right, let's talk about the check-in process. When the patient arrives at the healthcare facility, a staff member must verify the patient's identity by copying or scanning the patient's insurance card and checking a driver's license or other proof of ID. Verification of identity is necessary to ensure proper rendering of patient care and to lessen the opportunities for insurance fraud. Following the proof of identification, a copy of the patient's insurance is scanned into the EHR and consents for treatment, billing, notice of privacy practices acknowledgement, and release of patient information for billing and continuity of care are signed. The patient's insurance is verified and the copayment is collected from the patient. All right. Most acute care facilities that use an EHR system call their list of patients a master patient index or a patient list. The MPI is a database created by the healthcare organization to assign a unique medical record number to each patient served, thus allowing easy retrieval and maintenance of patient information. Typically, the EHR system automatically generates and assigns a unique patient number or medical record number, also known as the patient identification number. HIPAA proposes the implementation of a unique patient identification system. In this system, a patient identifier is generated that has a purpose similar to a Social Security number. The patient identifier consists of a set of numeric or alpha characters that seamlessly connects a person to his or her healthcare information. It is crucial that healthcare providers use the MPI to verify that the patient only has one patient identifier. If a patient has multiple identifiers, then providers may not see the true picture of a patient's health status because important healthcare information may be misplaced, lost, or duplicated. The EHR system stores the MPI permanently, and the following are goals of the MPI. First, match the patient with his or her MPI record. Second, minimize duplication. Third, merge and enterprise the MPI. And fourth, retain lifelong health records. An efficient and effective MPI system makes it possible to meet these goals. The American Health Information Management Association recommends searching for a patient based on core elements. For indexing, in an MPI, the core data elements of a patient record include the following: medical record number, name, date of birth, sex, race, ethnicity, address, previous name, social security number, facility identifier, account number, admission date, discharge date, and service type. We also have some optional data elements for the MPI, and these are your marital status, your telephone number, mother's maiden name, place of birth, advanced directive notations, organ donor status, emergency contacts, allergies, and your problem list. Now, talking about Enterprise Master Patient Index, as healthcare continues to incorporate acute care and ambulatory care practices, there is a need to maintain patient identifier information across an EHR system for all healthcare settings. This system-wide database is called the Enterprise Master Patient Index. The eMPI allows a healthcare organization to compile the patient's information into one index using registration, scheduling, financial, and clinical information. Two key data elements differentiate the MPI from the eMPI: the Enterprise Identification Number and the Facility Identifier. The EIN in the eMPI is an identifier used by the organization to identify the patient across various healthcare settings, whereas the Facility Identifier is used to indicate a healthcare setting where the patient is seeking care. Healthcare providers have created a system in the EHRs that automate the data elements in the patient record. Recommended eMPI data elements include the following. In the book, you'll see this on page 114. It includes the EIN, Facility Identifier, Internal Patient Identification, Patient Name, Date of Birth, Sex, Race, Ethnicity, Address, Social Security Number, and Telephone Number. All right, moving on to patient registration and admission. The patient registration and admission process may be slightly different for acute care and ambulatory care settings, but personnel in both settings focus on collecting accurate patient information. As mentioned earlier, the registrar is typically the first person the patient approaches upon arrival to the care facility. The registrar collects demographic and administrative information from the patient. If the patient is already in the EHR system, then the registrar will verify the accuracy of the information. Although similar to the registration process for ambulatory care, acute care personnel must follow the UHDDS for inpatient care. Developed by a committee in 1969, the UHDDS outlined the set of patient-specific data elements. This protocol, revised by the National Committee on Vital and Health Statistics in 1984, was adopted by the Federal Health Programs in 1986. But since then, the UHDDS has been revised several times. The core elements are going to include your patient identifier, your date of birth, sex, ethnicity, address, healthcare setting identification, admission date, type of admission, discharge date, attending physician identification, surgeon identification, principal diagnosis, other diagnoses, qualifier for other diagnoses, external cause of injury code, birth weight of a neonate, significant procedures and dates, disposition of the patient, expected source of payment, and the total charges. All right, moving on to ambulatory care registration. In an outpatient or a physician office setting, the front office staff usually handles the registration process. This information gathered in the outpatient setting should follow the UACDS for outpatient services. The primary purpose of using this data set is to ensure that all healthcare setting and providers are gathering identical types of information on each patient and that the data collected is defined consistently across healthcare settings. The NCVHS approved this data set in 1989. The UACDS is used in surgery centers, physician offices, outpatient clinics, and emergency departments. Now, some of these data elements include patient identification, address, date of birth, sex, ethnicity, provider identification, provider address, provider specialty, place of encounter, reason for encounter, diagnostic services, problem, diagnoses and assessment, therapeutic services, preventative services, disposition, source of payment, and total charges. All right, so now we're going to get into how we determine a new versus an established patient. So for the purposes of admission and registration, a new patient is defined as a patient who has not received any services from a provider or a provider in the group of the same specialty and subspecialty within the last 3 years. So this could be a brand new patient. They've never ever received service from this physician or from a partner in that same practice, or it could be someone that saw a physician in that office 4 years ago or 3 years and 2 days ago. That would be considered a new patient. So to add a new patient to the system, the registrar must collect administrative information, including demographics used to identify the patient, report statistics, conduct research, and allocate resources. Demographic information gathered is going to include first, middle, and last names, their medical record number, address, telephone numbers, home, work, and cell, sex, date of birth, place of birth, marital status, ethnicity, social security number, emergency contact, date of service, physician, and their dentist. Now, if we have an established patient, established patients have received professional services from a healthcare provider or a provider in the same group and same specialty and subspecialty within the last 3 years. So I could have seen someone in that practice 2 months ago or 2 years and 11 months ago, or 2 years, 11 months and 3 weeks. As long as it's within 3 years, I'm still considered an established patient. So the process begins searching for the patient to determine whether the patient record is in the EHR Navigator. There are multiple ways to search for a patient using a variety of criteria, such as the following: the patient's full or partial name in the last name and first name fields, the patient's medical record or patient number in the patient record field, or the patient's date of birth in the date of birth field. Healthcare staff members can also use a combination of these criteria to find an established patient. So they could put in the last name and then they could put in the patient's date of birth. So when searching for an established patient, search by different core data elements such as the patient name, patient record number, date of birth, social security number, or admission date to ensure that the patient record exists in the EHR system. If the patient is registered in the EHR system, the existing information needs to be confirmed with the patient. So you want to confirm their address, you want to confirm their emergency contacts, you want to confirm that they have the same insurance. All right, moving on to insurance information over on page 118. Insurance information includes details about the patient's insurance coverage, such as the insurance company, copay, and identification numbers to assist with processing claims. Some patients may not have insurance or may not wish to use insurance and are considered cash payers. The two key components of health insurance coverage are the subscriber and the guarantor. The subscriber is the person whose insurance coverage is used for acute and ambulatory care. The guarantor is the person or financial entity that guarantees payment on any unpaid balance of the account. And we'll get more into this as we get into Chapter 9. So when entering the patient's insurance and financial information into the EHR, you must also enter the patient's guarantor and guarantor account information. Subsequently, if an acute care ambulatory healthcare facility sends a bill for a balance of services or services not covered by insurance, then the bill is going to go to the patient's guarantor. A guarantor is the person or financial entity financially responsible for the patient. The guarantor may be the patient, another person, or a financial entity. Most patients older than 18 years old are their own guarantors. Minors usually have their parents or legal guardians as their guarantors. And any patient with decreased mental capacity typically has a guarantor. All right, and you can look at the different guarantor types. This is on page 119, table 4.2. You have personal and family. And then you have workers' compensation. We have third-party liability. We have corporate. Then we have research. So you can look through those, the description for each of those. All right, so let's keep talking about insurance information and how we update insurance information in the EHR. If a patient's current health insurance information is missing or does not match what is in the EHR, then the EHR will need to be updated, which is done by finding the patient's EHR and selecting the insurance menu option on the left panel. You can make changes to existing coverage and add new coverage. If changing existing coverage, it is important to enter the end date of the old insurance coverage to ensure that claims are submitted to the correct insurance provider. Now, we're getting into a lot of this, more of the stuff that you're going to actually see when you're doing your assessments in the EHR Navigator. So some of this stuff may not make sense if you listen to it before you go into the EHR Navigator. So just bear with me. All right, so let's talk about coverage of treatment. How insurance covers a patient's healthcare cost is based on the primary reason for the visit and a list of established insurance rules. So many rules. All right, so the first one, if a patient is injured, the healthcare setting must determine how the injury occurred. If it was an accident, primary coverage may be provided by the company, property insurance, or accident insurance. If a service at an acute care or ambulatory care setting is not accident related and each adult on the policy has his or her own insurance, then the patient's own insurance is primary. If a child is seen at an acute care and ambulatory care setting and there are two insurance plans that cover the child, then the birthday rule is applied. The birthday rule specifies that the insurance of the parent whose birthday falls first in the calendar year will be the primary insurance. The ages of the separate cardholders have no bearing on this rule. So, for example, if my husband and I both have insurance coverage for our children, so they're both on my policy and his policy, the primary insurance will be his, because although I'm older, I'm about 10 months older than him, his birthday is in February and my birthday is in April. So it doesn't matter about the age, it matters whose birthday falls first in the calendar year. So his insurance would be primary for my kids. All right, next one, number 4. If a patient has Medicare coverage and the services meet Medicare coverage guidelines, the primary coverage is going to be provided by Medicare. 5th, if a patient older than 65 years is being seen for something other than an injury, has two insurances, let's say they have Medicare and some other supplemental plan, they're unemployed, they're not covered by a spouse's insurance, then the primary insurance would be Medicare and their supplement will be secondary. Typically, a supplemental plan pays the deductible, copay, and any other charges not paid by Medicaid. And then last, if a patient has Medicaid and a private insurance plan, the private insurance plan will be primary and Medicaid will be secondary. So there's a whole bunch of insurance rules that, if you get into the whole billing world, that you would need to be familiar with. All right, moving over into adding information to a patient record. And I'm skipping through a lot of these slides about insurance. So over on 121, we talk about adding documents to the record. The EHR system gives you the ability to add scanned or uploaded documents to the patient's chart. The types of documents depend on the type of facility, but may include privacy notices, financial agreements, consent forms, and advance directives. All right, so we're going to talk about these 4 types. So again, these should be somewhat of a review for you. So let's talk about privacy notices first. Let's see if our slides continue. Yeah, we'll just go here. All right, so privacy notices is a rule. You have to have these signed, which is a rule based on the Department of Health and Human Services, and it informs patients about the use and disclosure of information by the healthcare facility. Document informs patients of their rights and responsibilities and provides contact information for any questions that they have. And so you can see an example of the Notice of Privacy Practices in Figure 4.8 on page 121. All right, then we have our financial agreements. An example of a financial agreement that may be attached to a patient's EHR is the Assignment of Benefits form. The Assignment of Benefits form is an authorization by the patient to allow his or her health insurance or third-party provider to reimburse the healthcare facility directly. All right, then we have our consent forms. A general consent for treatment form is used in acute care facilities. The patient or the patient's legal representative signs the general consent for treatment, giving the healthcare provider the right to treat him or her. The provider may require an informed consent if the patient is having a special procedure. A sample consent form is found on 123, Figure 410. And then over on 124, we have our advanced directives. This is a document that provides information about how the patient would like to be treated if he or she is no longer able to make his or her own medical decisions. So again, figure 411 on 124 is an example of your advanced directives. Okay, so that really covers the administrative piece. Administrative piece of your EHR, again, is going to be your registrar gathering the information about your patients, getting them entered into the EHR, etc. So again, go back through this chapter. Be sure to read that chapter summary. I'm not going to read the entire chapter summary, but we'll look at the slide. So ambulatory and acute care settings are the most common healthcare settings. We do have other settings which we looked at: long-term, behavioral, hospice, etc. MPIs and eMPIs are important for tracking patient visits and medical record numbers. And the design of MPIs are based on the NCVHS. And then AHIMA recommends a core data set for your database searches. The UHDDS and the UACDS inform data collection within acute care and ambulatory care. So uniform hospital and uniform ambulatory. So that's how you remember. Hospital is for your inpatients, ambulatory is for your outpatients. The difference between new versus established patients influences patient registration and admission processes. And remember, anything over 3 years, if you've not seen a physician in, like let's say you've not went to the doctor in over 3 years, then you're going to be considered a new patient, even though you may have been there 100 times before. If you have not been within the last 3 years, you will be considered a new patient. Accurate and timely collection of insurance information is important to patients and providers. And then additional forms such as privacy notices, financial agreements, advanced directives, and consent forms are important parts that may be signed and completed in paper format and uploaded to the EHR. So again, you can go through the end of this chapter and look at those acronyms and initialisms. A lot of this is going to be good for you just because I know several of the sophomores in past classes, they get ready to start studying for their RHIT exam and they're like, I don't know what these letters are. I don't know what this means. So use this book to your benefit. Learn what these acronyms stand for. And that's going to help you go a long way. So happy reading and happy studying, and good luck with your assessments in chapter